I'm going to talk today about Gabapentin, brand name Neurontin, which is the precursor to another gabapentinoid, that's the class, gabapentinoid, Lyrica, brand name or pregabalin. And I go back with this drug. I was an early adopter. The early pain docs, I was one of them, didn't have a lot of choices for neuropathic pain, nerve type pain, certain types of pain that were very resistant to traditional analgesics like opioids. We just didn't have anything. So we used carbamazepine, which is Tegretol, Dilantin. We used these other drugs that had baggage, and you had to get blood work, you had to monitor it, side effects. I can't tell you how many people had gingival hyperplasia, or that's where the gums get really big on Dilantin. Sometimes it has to kind of be cut away. I mean, who wants that kind of drug? But yeah, if you're hurting like some of these people did, yeah, you wanted those drugs. So out came a letter to the editor, right out of the middle of nowhere in 1994. And this low-level anti-epileptic drug or anti-seizure drug was found to be really pretty good. And you didn't have to get a lot of blood work, didn't seem to have a lot of side effects. It was clean. It was a clean drug. And talk about embracing a drug. It was a good adjunct. An adjunct is something we use so you get the 1 + 1 = 3 effect. In other words, you get an effect that tends to amplify another drug's desired effect. In this case, it was an opioid. And gabapentin does that. It does help diminish the opioid load. It's opioid sparing. And guess what? We do that with oxycodone and hydrocodone. We had acetaminophen, opioid sparing, theoretically. So there we were, using this drug off to the races. Like, here we are, writing that drug. How do you write the drug? Well, it's an anti-epileptic drug for certain seizures, and it's its label. So it's off-label. We're writing it off-label. Fine. Half of the drugs we write as healthcare providers, especially in the pain world, off-label. It might surprise you what is an off-label drug we use for pain, such as amitriptyline. It's an antidepressant, right? Well, we use it for myofascial pain. There are some indications for it. As an example, so Parke-Davis developed that drug. And Parke-Davis was a drug company. I don't think it exists anymore, but they went into naughty land. They did a few promotional things that really took a good drug and put it in peril. In other words, this drug was turned into be a blockbuster. And to give you some idea, even today it's a blockbuster. In 2017, I think it was the 10th most common written drug. That's a big drug. It's generic. Back then it wasn't generic. And so it was promoted off-label. Well, federal government had a field day with that, and they got into all sorts of litigation with the company. It was picked up by another drug company that's still around. It's a good drug, really a good drug, but they paid out a lot of money for using it off-label. Okay, so here I am. And I am a believer in fibromyalgia, and I believe we need to look neurologically at fibromyalgia. It's neuroinflammation, most likely at the glial cell level. It's in the weeds, isn't it? But wouldn't gabapentin work there? Might. So I was using that drug, and I approached the company. They approached me. It was kind of a simultaneously, hey, can we look at fibromyalgia with this drug? And this is on the heels of understanding that pregabalin was coming out pretty soon. That's the next generation gabapentinoid, and that would be labeled Lyrica. So I did a study, and you know, I had 1,000 pages of data and everything, and this thing came along with Park Davis, and that study I never published it. I published parts of it a different way, and I had written some work on it, but it was obscure. However, my data on fibromyalgia looked pretty good, and in fact, pregabalin was labeled for fibromyalgia. I doubt it was because of me, but in fact, let me tell you, it wasn't because of me, but it was recognized that gabapentinoids are really a good drug. So why are we here today? It's because I have been on YouTube learning how to do YouTube, and I check out related stories. Then I go to Facebook group, check out related stories. They are murdering this drug on YouTube, and they are presenting it in all sorts of unsophisticated, irrational ways that I just want to clarify. Okay, you want to talk everything over with the healthcare provider. That's standard disclaimer, and a qualified healthcare provider. But I've given well over 1 million doses of this drug. I get this drug. So, side effects. Yeah, it makes you a little sleepy, but that's good too. Because if you have trouble sleeping, vis-a-vis fibromyalgia, failed back syndrome, interstitial cystitis, a number of problems, gabapentin enhances stage 4. Stage 4 sleep is important because in pain, if you look at sleep studies, sleep is interfered at alpha-2 intrusion. What that means is you don't get to that deep sleep, stage 4. That helps with memory. It helps with refreshed thought the next day. And you've heard it, I just can't think. I can't remember anything. The Fibro crew, they know that well. That's the point. You can take a side effect to your benefit if you do it right. Another side effect is not necessarily a side effect per se, but it is an important consideration with the pharmacokinetics and pharmacodynamics, what the drug does to you and what you do to the drug. You throw it off when you saturate these little amino acid transport systems in the early part of your gut. That's the problem with gabapentin. A lot of it gets just thrown off. In the 90s, 2000s, we were given huge doses of this drug. 3,200 milligrams, geez, that's over 3 grams of drug. And a lot of that was just getting thrown off. A little is good, a lot's better. No, not with this drug. So, well, what do you do with that? You develop a drug that helps that transport system work better. They have that now. Brand name Graylease. It has a gastro-retentive technology. In other words, you got to eat a little fatty meal, and you take it at the time of the fatty meal, and it keeps the drug in the part of the gut it needs to be at to be absorbed better, so you don't saturate those transport mechanisms that get the drug in you. Okay? Another side effect. Well, yeah, if it makes you drowsy and you take it during the day, it's going to make you drowsy during the day, right? I mean, there's a number of side effects people can get into here that will limit its use sometimes. But the most important thing to know about this drug is it is unlikely to be a habit-forming drug. I'm not saying it's not. You just can't say it anymore. Starbucks coffee is. It's unlikely to cause significant withdrawal if you stop it abruptly. It can. I've read stories about withdrawal. And it's sometimes causes the typical complaints people say, and you read it in the PDR. headache, nausea, vomiting, that sort of thing, diarrhea. Well, somebody's going to have a problem and it has to be reported. The FDA reports it to the community, but the point is that's pretty rare. The withdrawal, I can't say I've ever seen it. I know it's probably happened, and if so, it was mild. Okay, application of this drug. Well, to understand all the withdrawal and all the other potential side effects, you have to understand the risk-reward benefit of using this drug. Well, it is a good drug. The risk, I think, exceeds acceptability on many levels. In other words, the risk-reward benefit's in your favor. Pretty much way in your favor. So we get relief from so many things. And so if it's good for something, what sticks on the wall? Well, we tried PTSD, we tried a number of psychiatric problems, psychosis, CRPS, we tried bipolar, a number of them, and you can read about them. It didn't really work very well. It didn't particularly work with addiction, and it was associated with potential suicidality. So there's this box. You go to the PDR and now it's potentially associated with suicide. I've never seen it. I'm not saying it doesn't happen. I've just never seen it. Okay. But what it helps with neuropathic pain, restless leg, yeah, really helps with restless leg. Hot flashes, go figure that. And I noticed this pretty early on. If somebody's itching a lot from stuff, it helps with that. It actually has been known to help with renal-induced pruritus or itching with renal failure. So if somebody has significant renal failure and they're on dialysis or whatever, they tend to itch. It's a great drug for that. So you can use the side effects and you can balance them against the benefits, and I think you're going to win on the benefits. Okay, so we threw it at a bunch of stuff, didn't stick, but we still use it for a lot of that stuff. I think it has enough of a calming effect on folks that they use it as an anti-anxiolytic drug, so it might help with a little PTSD. It might help with situational depression, anxiety. You just have to be cautious when you use it in people that have a little bit of trouble, struggle with depression. Okay, how does it work? Well, it's all over the internet. We don't know how it works. Yeah, we do know how it works. Alpha 2 segment subunit. It works there, and it works on this calcium gated channel. It has to do with how cellular activity works in the central nervous system. And it's this voltage dependent calcium channel really has a lot to do with cellular activity. Again, think glial cell, think central nervous system. It's not perfect in its explanation, but it looks pretty good. It's not necessary to go in exactly how it works, but to say we don't know how it works is not correct. It's okay, it's excreted renally, sometimes in the poopies. It really doesn't go through a lot of hepatic metabolism to really make that an emphasis. And it's a good drug to utilize in the drugs you worry about renal competition, methadones, hydrocodone, oxycodones, and all. Okay, so the bioavailability starts going down depending on, that means how it's available, depending on where it's going. It's only about 7% across the blood-brain barrier. It's not very high across the blood-brain barrier, but other parts of the Homo sapien, it works pretty well. And it tends to then benefit you with less worries about sedation if you can keep the dose low, because it won't have much going in the central nervous system. Okay, so there's not a lot of metabolism in this drug, not a lot to worry about metabolites. And it comes down to this. Why do they call it gabapentin? Well, It's structurally similar to GABA, gamma aminobutyric acid, but it's not. It doesn't have GABA effect. That's the hiccup on this drug. People think it's a GABA-like drug. There's GABA A and GABA B. So GABA B is like baclofen, a muscle relaxer. It does enhance stage 4 sleep. It's a good drug for spasticity. And there's GABA A. Ooh, GABA A is benzos. And GABA A has, as you can imagine, a lot of baggage. So there was a lot of concerns for a number of years because of that poorly chosen name. There's a GABA drug. It's not. So, okay, to summarize, okay, we have technology now to use this drug with gastroretentive technology and other technologies out there too that make it very acceptable to use in a number of age groups when you use it correctly and you ease into it. Okay? There's another brand, Horizon. This is a very good drug. It tends to be twice a day, and it has a good release characteristic. Great release. You can use the side effects to your benefit because you take the whole dose with your evening meal. Therefore, it's peaking when you're asleep. That's enhancing stage 4 sleep, right? So you're waking up better slept, and you might be a little perkier. You don't take anything in the morning. Patient dependent. We do know it probably enhances opioid activity at the dorsal horn of the spinal cord, or part of the spinal cord in the central nervous system, so it's probably opioid sparing. We do know this drug is readily available. It's generic and cheap. It's really a fine choice when used. Go low, go slow. So in that lollop, that little old lady in pain, start with the 100 milligram. Go into it slow. Older folks, they get the neuropathies. It's a great drug for that. Older folks get the restless leg. Great drug for it. So I hope that clarified a little on gabapentin and pregabalin. I will say this, that the most common complaint I get with that drug is a little bit of weight gain. Gabapentin less than pregabalin. Pregabalin has more weight gain, but it's not much. It's average. I think a study came out 2 kilogram, maybe 4 or 5 pounds with gabapentin, and it's usually reversible. It seems to be fluid, in my estimation. Pregabalin may be a little bit different mechanism, but that's really the most I hear. And folks that start these want these and are enthusiastic about continuing them for prolonged periods of time. It's okay to be on this drug. It's not a internally destructive drug. It's a pretty safe drug, and in the right diagnosis, right? Remember, rule 2, you gotta have a diagnosis. It's a fantastic choice. So if you could leave a review, it'd be great. If you have questions, let me know and I'll answer them. And it's pain information. I have a podcast too. I'll probably be talking about this stuff on the podcast. This is rule 4, no diet meds, right? So I'm going to be looking for other meds to help out here, help out in the understanding. And no, this is in most cases the world according to me, want me. But I think this is pretty good stuff, and this is pretty good experience. Use any drug with caution, but this is a good one.